رئيس قسم الهيماتولوجي او وحده الهيماتولوجي في كليه الطب المنوفيه. معلش انا تهت شويه، يمكن 3/4 ساعه بلف عشان لسه بقول للدكتور محمود ان اصعب حاجه انك تحاول توصل بجوجل بحاجه وراك على طول يعني. وده يبين ان التكنولوجي يعني مهما يتقدم له الشورت كامينجز بتاعته، وبالتالي مفروض ما نمشيش ورا حاجه. So for my talk today, I'm going to talk about something we have neglected or we have missed. All the horses back to track, and in particular, I'm going to talk about chronic myeloid leukemia from a rather different perspective. So the agenda for my talk today, we are going to discuss chronic myeloid leukemia. It's really a success story. أنا أذكر مع الدكتور عادل يمكن مع بدايات الكارير بتاع الواحد، كان الواحد ما بيقف قدام مريض كرونيك مايلويد لوكيميا بيتخيل تماما ان هو هيجي وقت ويكون بيعمل له resuscitation. It's a matter of 1 or 2 or 3 years or 4 years at max. He's going to transform into plastic crisis, and the standard therapy for plastic crisis at that time is nothing. So really, it's a success story, but every success we have to pay for. This is a principle in life, and this means we have a problem. So how to solve this problem? To stop the hope, the TKIs, in what we call treatment-free remission. So we use the drug for temporarily for a while, years or decades, and then try to stop. And what is the rationale for the treatment-free remission? What are the data we have, and the current practice, and the stopping rules, and whether this will solve the problem I'm going to talk about, and again, if not, how to solve this. So it's a success story, really, it's a success story. You can see the bottom line curve. You can see the overall survival of chronic myeloid leukemia in the 80s. At 10 years, you seldom see a surviving patient. Despite we have a lot of chemotherapy, including the standard busulfan at that time. And then there was some improvement, small step, with the addition of hydroxyurea. And then came interferon in the mid-80s. And it continued to be a new hope for chronic myeloid leukemia for almost a decade, with increasing the 5-year survival of myeloma patients into almost 50%. And then we're able to transplant those who are lucky enough to be fit and have a matched donor with a transplant, with an allogeneic transplant, and the dictum at that time is that chronic myeloid leukemia is going to die unless he has a matched donor and he successfully had a transplant. And we continue to improve the transplant outcome, and the debate to transplant or to give interferon was almost vanishing. And then suddenly, at the beginning of this century, the TKIs came to the ground. And suddenly, we had to stop immediately the transplant. So the STI stands for the chemical name of the drug and also stands for stop transplant immediately. And we have witnessed the dramatic improvement in the survival of patients with chronic myeloid leukemia. But again, we're not able to talk about cure. So we convinced ourselves that this is chronic myeloid leukemia and we don't have curative treatment for hypertension, we don't have curative treatment for diabetes. Let us add to the list chronic myeloid leukemia as a chronic illness rather than a dreadful tumor. So if you look for that dramatic and significant outcome with the TKIs and you compare it with those who do not have chronic myeloid leukemia, you can find that the survival is relatively the same. So as if there is no chronic myeloid leukemia, but you have to tell the patient he has to stick on taking the drug with very excellent compliance. We're talking about blood levels. We're talking about some automation or something to check the compliance of the patient by counting the pill, because his life lies inside this pill. So the corollary or the result of this improvement in survival is that the life expectancy of chronic myeloid leukemia patients approach the normal survival of the general population. What does this mean? Those in the past who had the diagnosis of chronic myeloid leukemia had shortened survival of almost 2 decades beyond their estimated life expectancy if the chronic myeloid leukemia illness was diagnosed at the age of 55. So once he has this diagnosis, he had to be convinced that he is going to lose 2 decades of his expected survival. After TKI, you can tell him and assure him you can almost run a normal survival. This is international, and this is a Swedish data telling you that how excellent we were successful in treating or controlling chronic myeloid leukemia. So you see the relative survival of chronic myeloid leukemia in the above line. If the patient is less than 50, it's almost the same as those who do not have chronic myeloid leukemia. And we started to have something new. In the past, we do not have a population of chronic myeloid leukemia. It's slowly growing because you have almost 100% deaths of all patients within 5 to 10 years. So it's not a cumulative disease in the population. However, suddenly, after the beginning of this century, you started to have increasing survival and increasing population of chronic myeloid leukemia patients to the extent as the year of 2010, those who are diagnosed after this age will expand in survival. So welcome to the club of chronic myeloid leukemia. Now we can have a club of chronic myeloid leukemia patients. Not only this, but if you compare the expected number of patients who will be prevalent in the US, this is from Cantorijan, he tried to estimate how many chronic myeloid leukemia patients will be surviving in the year 2050 compared to those who were surviving at the 2000, at the beginning of TKIs. In the year 2000, the US was having 20,000 CML patients. And it's expected at the year of 2050, this will approach almost 200,000 patients. So it will be a society of chronic myeloid leukemia. So how can we deal with this society? So is this a problem? Yes, this is a problem. Because you have to pay for this. And at least two parties have to pay. Number one is the patient himself, treated by chronic TKIs. Because TKI is not like aspirin. It has a lot to do with the impairment of quality of life. Not only this, the society also has to pay, because this will continue to be a financial and budget burden. So let us examine how impairment of the quality of life will be with TKIs, whatever it is first or second generation. And you can witness here in this table that all the TKIs have side effects. The least is fatigue. And even if you omit those to the right columns and satisfy yourself with the drugs we commonly have, you can have a specific impairment of the quality of life and adverse events with imatinib, including fluid retention and muscle cramps, with dasatinib, with hypertension and pleural effusion in almost 1/3 of patients, and arterial vascular disease and some hepatic impairment with nilotinib. So this is not unusual that you have to give some sympathy to patients who are controlled with chronic myeloid leukemia controlled with TKI. The second part of this problem is the societal impact, the budget burden we have. So I'll tell you in Egypt, how can we estimate based on some extrapolation from the data of cancer region in the US, assuming that we have almost 1/3 of the US population. So we'll not go too far to the year of 2030 to 50, but 2030, we can estimate that we'll have at least 40,000 chronic myeloid leukemia patients surviving and taking one of the TKIs. And even if you assume you are going to give all these patients the generic imatinib with the monthly cost of almost 1,000, so you have to pay for Chronic Myeloid Leukemia Society almost 500 million Egyptian pounds each year. Assuming chronic myeloid leukemia accounts only for 1% of the cancer population, you have to estimate that you ask the government for almost 50 billion Egyptian pounds for cancer care only each year. Is this affordable? If not, we have to solve. So the first problem is to stop the offending drug. If you have a drug that has some side effects or problems, stop it. Can we stop it, or we have to continue bearing this budget problem? Or you can ask the International Monetary Fund to give you money, and you know what do you mean by loans increasing and impact in the society. So you have to make some budget planning. You have to perform some financial solutions. And first thing is to reduce, the first idea is to use the generics. My calculations are based on almost generic. So it's not brand drugs. The second possibility is don't use the drug, or at least use it temporarily and then stop it. And this is the rationale for the treatment-free remissions. So why to stop TKIs is because of the above-mentioned problems. But can we stop TKI and cure chronic myeloid leukemia, or we have a recurrence and the patient will return back to his disease and probably may transform? So these are the several reasons why we have to stop TKIs after a while. And in addition, you have to put in mind, if you stop the drug, it's not ethical that you stop it without a hope of cure. You can't stop the antihypertensive for a patient with hypertension. You can't stop the diabetes treatment for patients who has diabetes unless you have a curative therapy for diabetes or for hypertension. So we were asking ourselves when we can kill the last leukemic cell. And based on some models for chronic myeloid leukemia, it has been supposed that at the time of chronic myeloid leukemia diagnosis, we have progenitors that are proliferating and giving you what you see in the blood picture and clinical scenario. And these patients are having leukemic stem cells at the time of diagnosis, enough to sustain this disease and possibly to transform it into a fatal transformed disease. So this is the stem cell depletion model with the hope that if you continue to give TKI, we know that TKIs are not that effective in attacking the stem cell, but there is some sensitivity of the stem cell to TKI. So we can hope that with time, we can deplete the stem cell and cure the chronic myeloid leukemia. But I'm afraid that mathematicians tells us, if you think in this way, the prediction model to kill the last leukemic stem cell is you have to continue the TKIs for 30 years. You have to continue the TKIs for 30 years to have this goal very realistic. And again, this is not realistic. So the second possibility, the second model is we do not need to kill the last leukemic cell because maybe at the time of chronic myeloid leukemia diagnosis, the stem cells are exhausted, are ill, they cannot pertain the disease. So maybe you can give the TKIs for 5 years, for 10 years, and you will reach cure. And the second possibility is also you do not, whether you really need to kill the last leukemic cells or not. Because you have an immune mechanism that in the first place has prevented chronic myeloid leukemia mutation from having transformed into a clinical disease in the vast majority of patients who actually do have the translocation 922. So the immune mechanism may contain the residual leukemic stem cell. This is a hope. So based on this, a lot of trials of treatment-free remissions, starting from STEAM and before STEAM. So the first person, actually, he is not a pilot. He is a French hematologist. This is Francois Mahot from France. And he started to think of stopping TKIs in patients who have undetectable disease and monitor the disease carefully. So Francois Mahon and Philippe Rousselot were able to present at the year 2007 the first presentation, the first pilot study of only 12 patients with undetectable MRD for 2 years and stop imatinib and monitor the disease. And they were able to show to the world that they were able to have 50% of these patients without recurrence. They remain treatment-free despite stopping the drug. So this is a hope. After this, a lot of treatment-free remission trials, including the first generation, second generation, third generation TKIs with or without interferon, came with different results. But this cartoon tells you how many small and large treatment-free remission trials with variable duration of TKIs. So I'm going to concentrate on the first regular trial after the pilot STEAM, the stop imatinib, in 100 patients who had sustained deep molecular remission with MR4 for more than 2 years, and then stop TKI and monitor the disease. And they were able to give this curve with almost 40% of these patients who will stop TKI without recurrence, molecular recurrence. The definition of recurrence was actually based on loss of complete molecular remission in the STEAM. So they thought this is not realistic because we do not read chronic myeloid leukemia as complete molecular remission, because if you have a patient with complete cytogenetic remission, you can be satisfied with this. So they define failure or relapse as loss of major molecular remission. And based on this, they transformed the second trial into STEAM, but according to STEAM, the difference is the definition of failure was to lose the MMR. And in additional 80 patients, they were able to show us that almost 60% or 60% of these patients were able to sustain a treatment-free remission. They were able again to convince other hematologists in Europe to stop TKI, and we have the largest trial with the EuroSki with almost 700 or 800 patients who had a TKI treatment for more than 3 years and MR4 for more than 1 year, and then stop TKI and monitor for the disease. This is the patient characteristics in summary, and they were able to show that if you move the bar, if you lower the bar of failure and transform from loss of complete molecular remission into just loss of major molecular remission, that we can almost have these patients surviving without failure of almost 60%. So what is the budget impact of this? In just 800 patients, EuroSki, it has been estimated that they have saved 200 million euros just for treating in this way 800 patients. Several other drugs, trials using in second generation TKI, including nilotinib and and dasatinib. And the bottom line is the treatment-free remission success rate is based on the depth of molecular remission you have at the time you stop. So it's ranging from 45 to less than 60%. So it seems to be a success that you can stop the drug. But is this realistic? to have success in 50% only? I'm afraid to say no. But after this, several guidelines have put strict criteria when to stop TKIs. You have to keep your patient on at least 3 years or more for TKIs, and he has to show deep remission for at least 2 or 3 years, or hopefully more than deep molecular remission with MR 4.5 for at least 2 years. Very strict conditions. The same with the ISMO guidelines. So it seems that this is very ethical to have rules when to stop treatment, effective treatment in a patient. So did this solve our problem? I'm afraid not. Because treatment-free remission, to me, using these guidelines and use these strict rules is something like elusive goal. الحقيقة الصادمة and that treatment-free remission is an elusive dream. And why I'm saying so? Because you have to tell yourself how many newly diagnosed patients at the end will be candidate for treatment-free remission trials to say the success rate is 50%. So if you have this, let's example, nilotinib, and you look for the deep remission with nilotinib at the reasonable time of 2 to 3 years, and compare it with imatinib. So at 3 years, you have a deep remission with MR4 with nilotinib after 3 years in only 50%. And you have to maintain these patients on additional nilotinib for additional 2 years before you stop. And if you go with the generic imatinib, you will be only able to reach this in only 30% of patients. So if you be patient enough and you have the budget, wait for 5 years and stop after additional 2 years, so this means total 7 years, again, this will rise only by 10%. So with treatment-free remission success rate of less than 50%, if you have this CML population and you give TKIs for 2 to 3 years, you will have almost one half having MMR, and less than 20% or more is deep molecular response. So if you restrict the stopping rules for those with deep molecular response, and you anticipate losing 50% of these patients, so at the end of the day, you are going to cure or operationally cure 10 to 15% of your patients. So only 1 out of 10 or 1 out of 6 of newly diagnosed patients will be free of medication, and the rest you have to continue to give TKIs. So even if you hope that the success rate with the stopping TKIs will be more than 50%, you can hardly reach 20%. So the treatment-free remission is a fact or fake. This is the ELN recommendation of treating chronic myeloid leukemia in the last version in 2020. And you can see they highlighted the cost and effectiveness of TKIs. And they were frank in saying there is a problem with cost and cost effectiveness and the quality of life. And they have several TFR discontinuation trials. But the bottom line is that they confessed that the conclusion is that, this is not my word, this is the ELN 2020. The conclusion is that the generic imatinib is the cost-effective initial treatment strategy, which means that even imatinib, if you give it for the brand, is not cost-effective. It will harm the budget. And not only this, but telling more the truth, they confessed that only 20% will reach the TFR success. And the majority, 80% of CML patients, this is their words, will never achieve a TFR. So, again, 80% will never reach the TFR. Financial solution, again, reduce the drug needed. Can we reduce, not stop TKIs, but reduce the TKI use? How? So what are the different scenarios you can do to lessen the use of TKI? First, in the first-line therapy, a front-line therapy, you may decrease the dose, the daily dose, or you may decrease the duration of therapy before you stop, or try to include more patients, more than the DMR, into the stopping rules, in the stopping trials, and try to decrease the molecular relapse in those who you have stopped treatment. So to stop, decrease the dose, lower the dose is okay, will decrease improve the quality of life and will decrease the budget burden. But is this effective? Can we reduce the TKI dose and keeping the same efficacy of the standard dose? And it's not me who answered this question. It's people at MD Anderson who published almost 1 year ago a comparative study between, it actually was not a randomized, it was a historical control study with a matched pair analysis. Those with taking just from, at the time of diagnosis, 50 compared to 100 milligram. And they presented the data in the TST meeting, the transplant cellular therapy meeting, and later, a few months later, in the last ASH meeting, the comparison of frontline lower dose dasatinib, 50 to the standard 100 in newly diagnosed patient upper score. And this was happening in 83 patients with the low dose and compared to a matched patients, control patients, 150 receiving 100. And you can look for the survival curves, the failure-free survival curves, and tell me which curve, the blue or red curve, belongs to the lower dose. The blue curve is the lower dose. So giving less dasatinib will improve the failure-free survival. So it will cut the cost if you plan to give dasatinib as frontline by 50%. And not only this, if you look for the molecular response and compare the low dose with the standard dose, with the 1 year MMR, 80% compared to 76%. The 1 year MR4, 60%, is almost less, more by 20%. So if you give lower dose, you get better results. So the conclusion is that lower dose is as effective, if not better, than the standard dose. Another trial adding to this, I remember a discussion I made almost 15 years ago at the time of launching of dasatinib, and I was telling Bristol Myers that what is the minimal effective dose of dasatinib? They don't know. At that time, they were saying it's 140. I told them it's 20. And this is the data from Japan. Dasatinib as low as 20 milligram per day will be enough. So although it's in only 22 patients, the majority of these patients were receiving dasatinib less than 20. You imagine, less than 1/5 of the dose you are giving. And look for these patient characteristics and then look for the results. The 1 year MMR with the low dose is 96% compared to 40% with the standard dose dasatinib and 30% with the standard dose imatinib. And not only this, the deep response with MR 4.5 at 2 years with the low dose dasatinib is 30% compared to 17% with the standard dose. So giving lower dose of dasatinib may be better than the standard dose. This is an ongoing study currently in Japan addressing this issue, and we are eagerly waiting for the result. So lowering the dose may be a way to solve. The second possibility is to shorten the duration before you stop, because faster and deeper response may have an impact in both the quality of life and cost. But again, is this ethical to do? Can you have the same efficacy, and how? So you have to think outside the box. You have to get bright ideas. Okay, let's examine if we can increase the dose. Maybe we have a better result. So in a shorter time. So giving a higher dose initially may save money later. However, we have the trials of high dose imatinib failing to show this. So can you add other drugs? Interferon, ruxolitinib, venetoclax, the antidiabetic pioglitazone, immune checkpoint inhibitors. I was not lucky to attend the discussion, the presentation of Professor Asami. I was lost in the road. So let us increasing the dose? No. So thinking of interferon is coming back, thanks to this man, Francois Gillot, again a French hematologist. And why he is thinking of interferon? Because interferon can act to stimulate the cycling of quiescent stem cell. It helps the re-entry of the leukemic stem cells that are dormant. So if you encourage the leukemic stem cell to return back to the cell cycle and give progenitors, these progenitors will be deleted or destroyed by TKIs. So in this way, you are going to deplete gradually the leukemic stem cell and decrease the recurrence. Not only this, but also because everybody knows how important is interferon in stimulating our immune system to monitor for the recurrence of leukemia by improving the antigen presentation and effective killing by T cell and natural killer cell. So gradually, if you use interferon, you can deplete the stem cell, you can stimulate the immune system, and it's not a problem that you may damage the cycling normal stem cell, because TKIs are much more active on the leukemic cells. So now you have some sort of synthetic lethality. You have targeting. You ask the malignant cell to grow and destroy the growing cell. So this highlights the second and third model of stem cell exhaustion and immunological mechanism. So Francois Maho was happy enough to start this trial, the STI prospective international randomized trial comparing STI imatinib with 400, 600 imatinib and interferon, imatinib and RSC, and he was able to show in the first year that if you compare imatinib with the combination of imatinib and low-dose beguilated interferon, which was very well tolerated, that although the MMR was almost the same, slight improvement in terms of interferon arm. However, if you look to the MR4, the deep remission you are looking for to stop the treatment was almost double, was adding interferon at 1 year, and you have the same data confirmed by the second year with MMR with MR4 of 40%. With the second year only with imatinib and low-dose beguilated interferon. So the results are not that encouraging, because if you look to the right, look to the at the combination compared to the single agent at 8 or 10 years, you have almost the same with regard to the molecular response with regards to the combination versus single agent. But if you look to the left and try to examine the outcome as the first or second year, and tell yourself how can you compare the same data of interferon plus imatinib and imatinib alone, you can be able to see that imatinib, interferon, will give you the same result of imatinib, but 2 or 3 years earlier. So you will reach your goal, but earlier, which means less exposure of the patient to the drug and less cost. So the spiritual take-home message of this spirit study is that at 8 years or beyond, TKI alone will achieve the same deep response and in the same percent of population if you add interferon. However, adding interferon will help to achieve this outcome at least 2 years earlier. And this means that if you plan for a TFR, it's better to add interferon from the beginning if you see that this patient is, should be included in the TFR trials. So adding interferon in the upfront in this patient is useful. Is this is the only the only issue? No, because we assume that interferon exposure will decrease the relapse rate after you stop the combination or you stop the TKI. So can it decrease really the relapse, the recurrence rate? Let us examine the hidden data. So this is the data from a Twister study in almost 40 patients who stopped imatinib, but the half of these patients were actually had prior exposure to interferon. They received interferon before giving imatinib. Although this is not a combination therapy, however, you will see the impact. This is the expected TFR success, 40%. But if you look for those patients who had prior exposure, not combination, just prior exposure to interferon, and compare it to those with not, you have with the imatinib only the success rate is 1/3. If you look for those who received interferon prior to imatinib, if they received it enough for almost 1 year or more, you have a 60% success compared to 20% if the duration of exposure to interferon is less than 1 year. So this means that interferon is doing something, even if you give it before giving the TKI. If you look to the appendix, I'm always trying to look to the appendix. Please, I'm advising everybody to look for the appendix, which it contains very important and hidden data in all trials. So look for the appendix of the STEAM trial, and look for the outcome in the STEAM trial for patients who had prior exposure. Look for the odds ratio of those who received or not received prior interferon. There is a reduction of the failure of almost 20%. And even the STEAM, the according to STEAM trial, you have the same. If you look for patients who had prior interferon, the molecular recurrence was 44%, 28% compared to 44% if the patient didn't have prior exposure to interferon. Even in the largest Euroski, they have patients who were prior exposure to interferon, and again look for the appendix, and you will see that the odds ratio of recurrence is 3 times if your patient do not have a prior interferon therapy duration. So interferon do something, yes, in terms of accelerating the response and decreasing the molecular recurrence. So what else you can do to decrease the relapse? The problem of the outcome after you stop is dependent on how you stop. So how you stop is important. So if you change the way you stop imatinib, may be important. So if you can have this policy, the standard policy is go and stop late with the MR and stop suddenly. This is our current practice. But what if you can go and stop wisely? Either you stop early and gradually in the UK study Destiny, or you stop early, which means that you have a less exposure to TKI with less adverse effects and less cost, and intermittently as in Optikema trial from Italy. So again, look to this cartoon. If you have one half of your patient having MMR, and these are with DMR, and this is the way you stop with, in the DMR, and you have half of these patients remaining in TFR. Can we expand this? Can we decrease the relapse rate by the way we stop TKI? And even can we think of including the MMR patients who are prohibited by the guidelines, by inside-the-box ideas, to go into the TFR trials? Can we include these patients in the TFR trials? Conservative people will say, okay, if you do this in the context of a trial, you will have this outcome. These patients will almost all will have molecular recurrence, and you have done nothing. But the hope and the idea is that if you do it in a smart way, you may be able to keep some of these patients in TFR, less than 1/3 and hopefully half. So this is the idea of this gentleman, the Destiny trial. The Destiny trial, this is Richard Clark from Liverpool, so we have two important persons from Liverpool. محمد صلاح طبعا نمرة واحد, وبعد كده Richard Clark. So what Richard Clark tried to say in the Destiny trial, the escalation and stopping treatment of imatinib, nilotinib, and Sprycel is to slow before you stop. Don't stop abruptly. So if you have halving your speed, مش عارف ليه مش متلونة, if you have your speed for 1 year before you stop, what will happen? They examined doing this in 170 patients. المهم هنا الحقيقة إنه ال 170 دول كانوا 50 not in DMR, 50 were in MMR, and 120 were in DMR. They have 1 year of de-escalation. They reduce the dose of the TKI to half, to 50% for 1 year, and then they stop. So what happened? If you have your speed, this is the patient population, look for the efficacy. Loss of MMR in the MR3 group, the MMR group, loss of MMR in only 20%. If you stop gradually. If you stop gradually in the MR4 group, the recurrence rate was 2%. Although this is not a very big study, but a very promising study. And time to relapse was a bit faster in the MMR, as expected. So this is the curves for those in MMR. You have the freedom from molecular recurrence. It's almost 80% in the MMR. This is what this means, that even patients with MMR can be candidate to trials of stopping imatinib or TKIs if you stop gradually. And you have a dramatic improvement in the DMR group only if you stop gradually. وكلهم بيرجعوا للمولكولار once they relapse بيرجعوا للريسبونس تاني if you return to the standard dose. الغريب بقى هنا ان كان there is no impact of having very long TKI duration versus less than that long duration with regard to the recurrence rate. In the quartile with the shortest period of TKI, أقل من 5 years, no recurrence. So look for these curves. This is the failure-free survival, failure-free molecular remission of the MR4, 72% at 3 years, and 36% at 3 years of the MMR group, which means that 1/3 of your patients with MMR can stop and keep remission if you go in this way. Another way to stop TKI is to stop it intermittently. This is the Italian way of stopping TKIs. So what was the design? This was published a few years ago. Effect and outcome of a policy of intermittent imatinib treatment in elderly patients with chronic myeloid leukemia, and updated 3 years ago. Molecular response and quality of life in chronic myeloid leukemia patient treated with intermittent TKIs, first interim analysis of the Optikema. This is the design of the optichema. They have the fixed intermittent policy. This is the initial اللي هي كانت في 2013 اسمها الانترم ترايل، وبعد كده عملوا قارنوها بالبروجريسيف intermittent trial. What they were doing in the fixed intermittent first year شهر أو شهر لا each other months ويكملوا كده 3 سنين. في البروجريسيف intermittent first year each other months, second year give 1 month and 2 months drug holiday. في third year give 1 month and 3 months drug holiday. What was the result? Loss of MMR في ال MR3 group 50%, في ال MR4 group 15%, keeping MMR in this Italian way. In the MMR, in almost half of the patients. If you stop imatinib in the MMR group in the Italian way, and in the MR4 group 85%. حتى الناس اللي هم lost ال MMR في الليست ال MMR ما حصل لهمش مشكلة. لا transformed ولا lost السيتوجينيتك الكومبليت سيتوجينيتك ريميشن وانس ان هم رجعوا الكونتينوس ثيرابي رجعوا تاني زي ما كان. طب الناس اللي كانوا keeping ال MMR دول 120 completed the second year, keeping MMR من ال 57 اللي هم 63 عيان 6 خرجوا من الترايل، ال 57 remained in keeping ال MMR. 2 words of caution actually for these trials, because these trials were actually done in patients with long duration of TKI, leukemia. So the median duration was 87 months, but the idea is brilliant. And having MMR was a risk factor for recurrence. The last study I'm going to tell you about how to stop TKI is the Tiger study. It's not certainly this. It's a German Tiger. The German Tiger study is nilotinib with or without beguilated interferon at low dose for 2 years, and then either you continue in the nilotinib arm in nilotinib for an additional 1 year, or big interferon alone as short-term maintenance. Big interferon alone as short-term maintenance, and then to stop. It's done so far in almost in more than 200 patients, and you can see the MMR with the nilotinib arm. The combination is better in terms of MMR and response. You can see in the bottom line, those who had interferon maintenance, they are having better outcome with regard to the DMR 4.5 compared to nilotinib alone. هنا أوضح شوية في السلايد دي. So the take-home message of my presentation is that we are under-treating CML by working with single agent upfront, neglecting riding the old horse, interferon. And we are over-treating CML by giving single agent TKI indefinitely. This is an over-treatment. And TFR is an elusive goal if you go by the guidelines using TKI alone. And TFR is a legal dream that can come true for most CML patients if you think outside the box, the guidelines, and use interferon in a short maintenance. I'll stop here and thanks for your time.